Okay, so welcome to today's session, which will be on arterial blood gas analysis. We spoke to a couple of people, and quite a few of you have asked for a teaching session on this because it's quite a complicated topic. It is very difficult, so if at any point you think that we're going too quickly or we go through anything that you don't understand, then just let me know and we can make sure that we cover it in proper detail, okay? So it is a little bit tricky, so try and bear with us with this. So the first thing to appreciate is with an arterial blood gas, it's a very, very useful way to get a rapid amount of lots of information from a patient very quickly. Normally when you take a blood test off, it takes hours for the results to go to the lab and be processed, whereas these can be run in minutes, so you can rapidly get a good idea of lots of different pieces of information about your patient. The main things that you can find are to do with what we call the acid-base status, so the pH, and the bicarbonate status, so that's acid-base. The other things that are useful are the levels of respiratory gases, so the oxygen and the carbon dioxide. And in addition to that, there's also very useful information about the potassium and sodium and calcium levels and the patient's glucose, which is very important because it's easy to miss that if you're concentrating on other things. And again, it's something that's very easy to correct very rapidly. And lastly, the lactate. And this is something that goes up when people aren't getting enough oxygen to their tissues, or if they're septic, for example, or they've lost lots of blood. It tells you basically how sick a person is. So this is another very useful indicator. But those are all things that you can find in lots of blood tests. The main things that you concentrate on the ABG, for this session at least, is going to be on acid-base status and on the amounts of respiratory gases. And that's really what the complicated things are. It's pretty easy to tell if somebody's glucose is low or high that you need to fix it by either making the glucose higher or lower. But with the acid-base, it's a bit more tricky than that. So that's what we're going to focus on today. And it all basically comes down to this. So in the body, you've got a mixture of acids and what we call bases or alkalis. And the normal human body has to function with a pH range, so an acid status, of between 7.35 to 7.45. So you've got lots of mechanisms in the body to make sure that you sit within this normal range. If something happens that causes you to shift into the acid side, then you've got lots of compensatory mechanisms that will try and bring you back into this base side, into the normal range, and the same vice versa as well. So it's all about trying to keep the pH within this range. The thing to remember, I'm sure many of you are aware of how pH functions, but just to recap, if the pH is low, then you're more acidotic. So a pH of 6 is more acid than a pH of 7. And if the pH is high, then you are more alkali or less acidotic. So a pH of 8 is more alkali than a pH of 7. Okay? Is everyone happy with pH and how that functions? Are there any issues with any of that so far? Okay, looks like everyone's quite happy. So, this slide looks complicated, but it really isn't too complicated if we just take it through step at a time. So your body has two mechanisms that it uses to mainly regulate your acid-base status: your lungs and your kidneys. And both your lungs and your kidneys can make you become more acidotic or less acidotic. And the way that they do that is the lungs, if you breathe more, so if you hyperventilate, then you breathe out lots of carbon dioxide, and the carbon dioxide levels in your body go down. And by breathing out all that carbon dioxide, it causes a shift in the balance of how your acid status in your body works and makes you become more alkalotic. So basically, breathing out lots of carbon dioxide shifts the equation this way and means that the hydrogen ions, or the acid, that goes down and you become alkalotic. So your lungs can make you become alkali by breathing more. Similarly, if something affects your breathing, so stops you being able to breathe properly, then your carbon dioxide levels will go up, this will build up, and you'll become acidotic. So that's how your lungs regulate your acid-base status. At the same time, your kidneys do a similar thing, but this time they regulate the bicarbonate status. And this is what makes your body alkalotic. So they can either start retaining or keeping hold of the bicarbonate in your body so you don't lose it in the urine, and that will make you alkalotic. Or they can start losing lots of bicarbonate into the urine, and that will make you acidotic. And that is the basis of everything that you need to know about ABGs and how your body's acid-base status works. Lungs breathe faster, make you alkalotic. Kidneys can retain bicarbonate to make you alkalotic, or they can lose it to make you acidotic, and that's all. That is a bit complicated. It will make more sense as we do example questions and you can kind of see how it works. But are there any questions with this so far? As I said, it is very complicated. Everyone happy? Okay, fine. So, just another summary. So the neutral state is to have a balance of your CO2 and bicarbonate where your lungs and kidneys are keeping your pH between 7.35 and 7.45. That's what the body is trying to do the whole time. So again, just another summary. If your CO2 level goes up because you're breathing less, you become more acidotic. If your kidneys start keeping bicarbonate, then you become less acidotic, and that's all. So with that in mind, you can interpret any arterial blood gas sample in the world by just running through these 6 very easy steps. And all it involves is asking 6 questions. You look at the arterial blood gas sample and ask yourself, is the pH normal? Then you look at the CO2 level and ask, does this CO2 level explain the pH? Then you look at the HCO3 level and ask, does that explain the pH? And then you look for any signs of compensation, which we'll go through. And then you look at the respiratory gases, so the levels of oxygen. And then you look at the other things, so the potassium, the sodium, the hemoglobin, and the lactate, glucose, all that other stuff. So we'll do an example to show you how this system works. But this is a really, really simple system that will let you be able to interpret any arterial blood gas sample that you come across. So 6 steps. We'll take this one as an example. So you've just gone to see a sick patient and you've managed to take off this arterial blood gas sample and you're holding it in your hand, the printout that comes out of the machine, and this is what you can see. So we'll start off with the first question. So with the pH, is it acidotic or alkalotic? Good, so pH 7.33, that's lower than the normal pH, so this patient is acidotic. So, step 1, pH acidotic. Question 2, is the pH explained by the is the pH explained by the CO2? So you look at the CO2 levels, you ask yourself, are the CO2 levels high or low, and does that explain the pH? Yep, so the pCO2 is high, and we said when you have a high CO2 you become acidotic, so the pH is explained by the CO2. That means that this person has an acidosis and it's caused by the respiratory center, so they've got a respiratory acidosis. So we've made the first part of the diagnosis already. This patient has a respiratory acidosis. Next, is the pH explained by the bicarbonate? So the bicarbonate in this case is high. So is the pH explained by the bicarbonate? Good. So everyone's agreed the pH is not explained by the bicarbonate because, as we said, the bicarbonate is high and that will make you alkalotic, but this patient is acidotic. So this is not a metabolic acidosis. This is, as we've already established, a respiratory acidosis. It's actually the third question, is there any compensation? So by compensation, we mean, is the body doing something to try and correct the abnormality? So we can see the abnormality is the pH is acidotic. And there are two ways the body can correct this, as we said. One is with the lungs, one is with the kidneys. Either you can breathe faster and blow off your CO2, and that will try and correct this. But this person's actually got the reverse. They're acidotic because they're not breathing enough, so they can't do that. Instead, what their kidneys are doing is they are retaining bicarbonate. They're keeping hold of this bicarbonate ion, and that makes you become alkalotic. So they've actually got a high level of bicarbonate, which is the opposite of the pH. So the body is trying its best to try and compensate for this. So if the body hadn't been retaining this bicarbonate, this pH would have been a lot lower. They'd been more acidotic. So there is compensation. And when the kidneys are compensating, we call that a metabolic compensation. So this patient has a respiratory acidosis with a metabolic compensation. Does that all make sense so far? So are there any questions? Okay, we have a question, so feel free to type it into the box and we'll answer it. Whilst you're typing, we'll continue with the PO. So the body always tries to compensate, but it takes a little bit of time. So if, say, something's happened suddenly, the body hasn't had time to compensate, and so it will be an uncompensated acidosis or alkalosis. So if it's just someone's, say, taken, their breathing has just suddenly stopped and they become acidotic because they're not breathing, the kidneys haven't had a chance to retain any bicarbonate, so that would be an uncompensated respiratory acidosis. In this patient, the fact their kidneys have had time to compensate and it is a compensated acidosis, that means that this must have been going on for a while and the kidneys have had time to do something. So it's not always compensated, but it often is. So the next step is to check the PO2, the oxygen saturations. Basically, what we're looking for here is signs of respiratory failure. And respiratory failure is defined as effectively you're not getting enough oxygen into the bloodstream. And when we take off the sample, we can see how much oxygen is in the bloodstream on the PO2 section. And respiratory failure is defined as a PO2 of less than 8 kilopascals. So if the body is not getting, if the oxygen tension is less than 8, then there's a respiratory failure. And there's two types of respiratory failure to be aware of. What we call is type 1. And what this means is the lungs aren't able to diffuse enough oxygen into the blood. So the oxygen is getting into the lungs and it's not getting from the lungs into the bloodstream. That's the first type. So the lung itself isn't managing to get the oxygen from it into the blood. And what that does is that makes the CO2 stay about the same. So it can either be low if the person is breathing a lot trying to compensate, or it can be about normal. The second type of respiratory failure, this is not so much a problem about getting the oxygen into the blood, the problem is about getting air into the lungs. So in this situation, the CO2 builds up as well because your lungs, the patient's effectively not breathing. In addition to the lungs not getting enough oxygen in, they're also not able to get enough CO2 out. So it's basically the lung pumping failing. So in this case, you get a high CO2. So in type 1 failure, not enough oxygen can get into the blood from the lungs, and in type 2 failure, the lungs themselves aren't breathing. And the causes of these two types make sense. They explain both those things we just talked about. So in type 1, the CO2 will be normal, and in this case, there's problems. So if you've got a pneumonia, then the oxygen can't get from the alveoli into the blood. If you've got pulmonary edema, there's lots of fluid everywhere, so again, the oxygen can't get into the lungs properly, into the blood properly. And the same with the other causes. So if you've got a pulmonary embolism, then you're blocking off the blood supply to get into the part of the oxygen where it needs to be. And in type 2 respiratory failure, this is a problem with breathing itself. So neuromuscular, the muscles that make the lungs work, aren't functioning, or if the thoracic cage is deformed, then they're not able to shift enough oxygen in and out. And the same with asthma, if they start to get very tired, they're just physically not able to breathe enough. So that's the two types of respiratory failure. Are there any questions about respiratory failure? All right. So we looked at causes of respiratory failure. Now that we know how to work out whether somebody's got an acidosis or an alkalosis and whether that's respiratory or metabolic, the reason that's important is it gives us an idea about the underlying diagnosis, so we can come up with a differential diagnosis. So with a respiratory alkalosis, as we said, that means the person's breathing too much, they're hyperventilating. If you, for example, were to sit there and take lots of deep breaths as fast as you can, you will eventually give yourself a respiratory alkalosis. And that often happens to people who are stressed or anxious and start breathing too much and panicking. That can be one of the causes. Alternatively, if somebody's having something affecting their breathing, they can try and compensate because, again, they get panicked. So if you've got an asthma attack, first thing you'll start doing to try and get enough oxygen in is breathing lots and lots. And in the initial phases, you might cause a respiratory alkalosis whilst you're breathing to try and compensate for the fact that your airways are closed. And it's the same for all of these other causes. These are all things that make somebody breathe more, and that causes a respiratory alkalosis. A respiratory acidosis is the reverse. So, as we said, it's basically the causes of type 2 respiratory failure, things that don't let the patient breathe properly, like problems with their muscles or if they've got a thoracic cage problem. And the causes of metabolic alkalosis, so this is not enough acid, either the patient is losing acid from somewhere, so if you start vomiting up your stomach acid, then you'll become alkalotic, or if you start losing acid through the sweat in the skin in people with cystic fibrosis, those sort of things, then they can get metabolic alkalosis as well. Or alternatively, you could be building up bicarbonate. So drugs that we give people, certain types of diuretics, they can cause the kidneys to retain bicarbonate, and so you can become alkalotic. Or they can ingest a poison, something that's got lots of alkaline in it, and that will also give you a metabolic alkalosis. The last one's a metabolic acidosis, and this has actually there's two types of metabolic acidosis, and that lets you help with a differential diagnosis as well. So either you can be acidotic, because you've added a foreign acid to the body. So if you've swallowed lots of battery acid or ingested something that's acidic, or your body has started producing an artificial acid, like in diabetic ketoacidosis, your body starts making ketones which are acidic. You've added a foreign body, and that causes you to become give you a metabolic alkalosis. Alternatively, you can start losing alkali. So if you are having, say, a fistula, a part of the bowel is leaking out lots and lots of alkali into the outside, that can cause you to become acidotic as well. And the way you differentiate between those two, on the arterial blood gas, it can tell you which one of these two things are happening. And what we do is we look at something called the anion gap to tell whether the person is acidotic because there's a new acid being added or if they've lost their own alkali. And the anion gap, again, this is a bit tricky, but what we're basically doing is on your arterial blood gas, you can see the levels of these different things. And there's an equation that lets us work out the anion gap. And what we do is we take the positive ions, so sodium and potassium, we add their concentrations together, and we subtract the negative ions, so the chloride and the hydrogen, the bicarbonate. And in a normal healthy person, the range is somewhere between 7 to 16 or 18. That's sort of the normal range. So that sounds a bit complicated, but we'll go through what this means. So, just to summarize, so a raised anion gap, if the patient's had an acid added to their body, the anion gap will be up. So this equation will be greater than 16 to 18. There's lots of things that cause that, but there's a mnemonic called mud piles that people sometimes use to remember. But it doesn't matter for this stage. Just to remember that means something. So they've drunk lots of methanol or ethylene glycol, which is antifreeze, or their body started producing acid from diabetes and those sort of things. Alternatively, if the anion gap is not raised, then that means they're lost bicarbonate, maybe from diarrhea, or their kidneys aren't functioning with renal tube acidosis, or they've got a surgical fistula that's leaking bicarbonate out. And we'll run through this example to try and get an idea of what this all means. Okay. So this is a 45-year-old man who has been found collapsed in his car garage. So we'll work through our system. So here's the pH. Here's the pH acidotic or alkalotic? Okay, so he's acidotic. The second question in our system is, does the CO2 explain the pH? Is this acidosis explained by the CO2? Okay, so people are saying it's not explained, and that's correct. So if you were, if the CO2 was causing the acidosis, the CO2 would be high, but the CO2 in this case is actually low. So this is not a respiratory acidosis. In that case, is the CO2 explained by the bicarbonate? Is the third question in our system. Good. The acidosis is explained by the bicarbonate because the bicarbonate level is low, and we know that bicarbonate makes you alkali, so when it's low, it means it's making us acidic. So therefore, this must be a metabolic acidosis. So it's an acidosis that's caused by low bicarbonate. So base excess, all this is, it's something that you see on the arterial blood gas sample, and it runs an equation that it's exactly the same as the bicarbonate effectively. It takes the bicarbonate level, and it's sort of telling you how much extra acid you would have to add to somebody to make their pH normal. It's just a different, some people prefer it to the bicarbonate level because the numbers are smaller, but it's basically exactly the same thing. It's just another way of representing the bicarbonate, and the range, instead of being these values, is about +2 to -2. So in our system, we've said the pH is acidotic. It's not explained by the CO2. It's explained by the bicarbonate. So this is a respiratory acidosis. The third question in our system is there any compensation? So is the body doing anything to compensate? It can either compensate by using the lungs to breathe more or less CO2 in or out, or it can compensate by using the kidneys to balance the bicarbonate. So if you've got a metabolic acidosis, you can get a respiratory compensation by breathing more CO2 off, or if you've got a respiratory acidosis, you can get a metabolic compensation by your kidneys retaining some of the bicarbonate. So is there any compensation happening at the moment in this patient? Yep, so there is compensation. We said that they had a metabolic acidosis, and their CO2 levels have gone down to try and compensate for that. The body is trying to blow off the carbon dioxide to make you more alkalotic and try and compensate for the fact that you have this metabolic acidosis. So this man has a metabolic acidosis with respiratory compensation, so that's part of our system. The next question, when we've got a metabolic acidosis, we said we look at the anion gap. So the anion gap, as we said, is the positive ions minus the negative ions. And if we take those individual factors, so we take the sodium concentration, which is 134, we take the potassium concentration, which is 4.5, and we subtract the chloride concentration, which is 101, and the bicarbonate, which is 12. So in total, we get so that equation is missing the bicarbonate level, but in total we do get a high anion gap which is over the 16 to 18 range. So this patient has a high anion gap metabolic acidosis. And if you have a high anion gap, does that mean that you've got an additional acid or you have lost alkali? So as we said, if you've got a high anion gap, it means there's something added to your bloodstream that's causing the acidosis. So there is a foreign acid that's been added to this patient's body. The reason this works is what we're trying to do is when the arterial blood gas analyzer, it looks at these ions, and these ions are the things that give the patient the level of what we call they give the patient an anion gap that exists based on these ions. If the gap's bigger, it means there's something else that's been added that's made this gap wider that we can't test for. So the analyzer can't see it, but we know that the gap's bigger than it should be. So there's something the analyzer can't see, and that's why it's a foreign acid. If it was normal, the analyzer can see all of these things. So if you've lost some bicarbonate, the analyzer will pick that up, and so the gap will be the same. We'll still see the same level. It just means that there's something that we haven't been able to visualize. So high anion gap means a foreign acid has been added to the body. In this patient, so a common example of this, somebody in their car garage, antifreeze, ethylene glycol is a poison that often causes a metabolic acidosis, a very common cause. So that's the sort of thing that you would look for in somebody in this situation. So he's got a metabolic acidosis with respiratory compensation, which we all established, and a high anion gap. Right, so the best way to get a feel for this, because it is a complicated topic, is just to sit and practice through some cases and try and see what we can understand from them. So again, always go back to the same 6-point system. So we'll run through it again just to make sure it's really easy. So is this pH normal or sorry, one second. Is the pH acidotic or alkalotic? Good, it's alkalotic, the pH is high. Next, does the CO2 explain the alkalosis? So does the carbon dioxide level explain the fact that she's alkalotic, this patient? Yeah, absolutely. So the CO2 is low, and when the CO2 is low, you become alkalotic. So this is a respiratory alkalosis. So before we go on, can anyone think of what could be causing this? It's a 20-year-old young lady who's feeling short of breath, has got exams next week, and she's got a respiratory alkalosis. What sort of things are going through your mind at this point? You can type an answer in the box on the side. Possibly, medicines can do this sort of thing, but common things are more common, so that is definitely, you'd always look for all of this, but if somebody the key factor in this is she's told you she's got lots of exams coming up next week, and she's got a respiratory alkalosis. She's quite a stressed person. When you see her in the emergency department, she's looks very healthy. You do the rest of the examination, everything seems normal. You tested her other blood tests, they've all come back as normal, and she's just very, very anxious. So this is a common thing you might see in somebody who is having a hyperventilation panic attack, somebody who's very, very anxious. So she's just breathing lots, because of the fact that she's stressed about something. So she might be having a panic attack. So first step, pH is alkalotic. It is explained by the CO2, so this is a respiratory alkalosis. Is it explained by the bicarbonate, the pH? So the answer is no. The bicarbonate does not explain the pH because the bicarbonate is low and the patient is alkalotic. When you have a low bicarbonate, you should become acidotic. So this pH is definitely being caused by the fact she's breathing too much. She's hyperventilating. The last question is there any compensation going on? So this respiratory alkalosis we've diagnosed, are the kidneys doing anything to compensate for it? Are they retaining, so are they losing bicarbonate in the way they should be? Good. So it's probably quite an acute thing because she's not had, her bicarbonate levels are a bit on the lower side, so she might have been doing this for a while, but they still haven't gone into the abnormal range yet. So her body, this has probably happened quite suddenly. Her kidneys haven't had a time to compensate. So that's the sort of thing that you would expect to see in somebody who's having a panic attack. Good. So, always again, going back to our system, the other thing to make sure we don't miss out on are we look at the PO2 levels and the remaining ions, and they are, in this patient, they are, the remaining O2 level, as you can see, is in the normal range, so she's not got any respiratory failure happening. And the other ions aren't given here, but that's something you always remember to check. So this is an uncompensated respiratory alkalosis in this patient. Next, this is a 17-year-old girl who's come into the accident and emergency department. She's had an argument with her parents, and she took an overdose of an unknown tablet. Again, working through the system, is this patient acidotic or are they alkalotic? Good, she's alkalotic, the pH is high. Is the pH explained by the CO2 level? Yep, the pH is explained by the CO2 level because the CO2 is low and she's alkalotic, so she's having a respiratory alkalosis. Is the pH explained by the bicarbonate? Good, the pH is not explained by the bicarbonate because she's alkalotic and it's on the lower side. Is there any compensation happening yet? Are her kidneys compensating for the respiratory alkalosis by losing bicarbonate? Good, there's no compensation happening, and the O2 levels in this patient are normal. So this person's having an uncompensated respiratory alkalosis as we had last time. But with this person, as things go on, she's got her uncomplicated respiratory alkalosis that you initially diagnose. But then a few hours later, she starts complaining of hearing ringing in her ears and she's starting to get a bit more unwell. So you do another arterial blood gas sample, and this is what you see. So with the base success and the HCO3 question, it is literally they are both effectively the same thing. The ranges that the labs use might vary between different labs, but if one is in range, the other one is roughly in range. If you're on the borderline, just because of the way the labs run them, they might look a bit different. But a lot of people ignore the base success, and a lot of people can ignore the bicarbonate if people just tend to choose the one that's easier. The bicarbonate makes more sense intuitively because you don't have to run a second calculation to work it out. It's the more simple way to work it out, and it tells you exactly the same thing. But going back to this case, so she had her respiratory alkalosis. She was breathing too much. She was hyperventilating. And a few hours later, she's now got ringing in her ears, and this is her blood gas. Is the pH acidotic or alkalotic? Good. So she's very acidic now. So that's interesting. She was earlier when she came in having a respiratory alkalosis. Now she's become acidic. So what's going on? Is her CO2, does that level explain the alkalosis? Does her CO2 explain the acidosis? Sorry. No, it doesn't explain the acidosis. That's right. So she's acidotic and her PCO2 are low. If the CO2 was contributing to the acidosis, it would be high. So she had this respiratory alkalosis. She was hyperventilating before. She's still hyperventilating, but something's changed. It's actually made her alkalotic this time. So we asked the question, does the bicarbonate this time, does that explain the acidosis? Does the bicarbonate explain what's going on? That's right, yes. So the bicarbonate does explain this acidosis. So she's now got, in that case, a metabolic acidosis. So she started off with a respiratory alkalosis. She was hyperventilating, and then something happened, and she went into a metabolic acidosis. That's very, very classic of a very particular drug that she might have overdosed on. So there's one thing in particular that tends to give you this exact picture, especially in somebody who's complaining of ringing in the ears. Does anyone know what that thing might be? I'll put on some options. So which one of these drugs do you think might give you the picture of what this girl has described? Excellent. So try and remember this pattern that you see. So somebody has taken an overdose of a tablet and they get a respiratory alkalosis. They start hyperventilating, and then they get a metabolic acidosis. So they get a mixed respiratory alkalosis with metabolic acidosis. That is typical of aspirin overdose. So somebody who's taken a salicylate poisoning. So that is what this situation is. It is a patient who has had an aspirin overdose. The reason this happens is the aspirin, one of the effects of salicylate, which is in aspirin, is it causes the respiratory breathing centers to be stimulated, and so the patient starts to breathe. And then later, as the aspirin gets broken down and processed, it creates a metabolite that makes you acidotic, and at the same time, it disrupts your body's normal ability to process ions and things the way it should, the energy in the way it should be, so you become acidotic as well. So a person who's taken an overdose of tablets, who gets a mixed respiratory alkalosis and a metabolic acidosis, especially with the classic sign of ringing in their ears. It's one of the side effects of aspirin overdose. They get a ringing in their ears. If you see that, then you know that this patient, that at least one of the drugs that they've taken their overdose of, is most likely going to have been a salicylate, so aspirin. And that is how you read ABGs. It's as simple as that. It has a very complicated sort of background and all those things, but as long as you always go back to a system, follow these 6 very, very simple steps, then you'll always be able to work out what the picture is and what's going on. You check, is the pH normal? Is the pH explained by the carbon dioxide level? Is the pH explained by the bicarbonate level? Any compensation happening? Then you make sure you check the O2 levels and everything else like the potassium, the sodium, the lactate, glucose, and hemoglobin. But those are just normal blood tests that you just look at the levels high or low. Okay? Does that all make sense to everyone? Are there any questions on any of that? We can go back over anything that didn't make sense or you want some clarifying on. Are there any questions? Good. Okay. Well, hopefully that was useful. It gives you a bit of an idea of how to approach ABGs in the future. This video will be available online for you to watch later as well if there's anything you want to recap or go over. But as we mentioned, that's just a case of always having a system whenever you go over anything that's a bit tricky in medicine. So thanks very much for coming to join us. If you could fill out a feedback form that's on the link that's just been posted on the right, then that will help us to try and make our tutorials better and more useful for you in the future. We're going to try and keep doing these regularly, so make sure you keep an eye out open for when we have the tutorials and log in. But other than that, I hope you've all enjoyed it and have a good rest of your day. Thanks very much.